And thank you for the not only the introduction but for the invitation. Great way to start the conference with Dr. Little. She was drilling down more at the model of obviously collaborative care, integrated care, from originally known as the Impact Model. Hog Foundation, we were there at the beginning 20 years ago. We were the ones that funded 6 original sites across the state of Texas. Dr. Little was involved. So really great to sort of refresh and hear that from her. So I'm going to take you all back. So I want you to pull back, and we're going to talk big picture now. Remember, she mentioned population health. So I'm going to be talking about those issues because, as you know, I'm really going to be drilling down on why health equity is so important. Well, before I do that, let me talk a little bit about the Hog Foundation. The picture there in black and white, that's the first leader of the Hog Foundation, the tall man. That was Robert Lee Sutherland, Dr. Sutherland, and he's with Miss Ima Hogg. So the Hogg family is the one that actually helped to create the Hog Foundation. It all comes from old oil money. They're a Houston family, if you're not aware of it. It's one of the great, I think, philanthropic organizations that was created in the 20th century from oil. The family, the way they saw it, was that the great state of Texas provided them with all this wealth. And they felt compelled that they should give back to the state of Texas. And their father was the first native-born governor of Texas, Big Jim Hogg. He had 4 kids, only 1 daughter, 3 boys. All of them were philanthropists to a certain extent. But Ms. Ima, being the girl and the woman, she really kind of led the charge. And it's because she grew up with her dad as he was governor, and she would follow him and go along as he visited state hospitals and institutions. Of course, at the time, they called them asylums. And it really greatly influenced her. She also, though, dealt with depression herself through as she also went and became a young individual and a young woman, and I think that also had additional impact on her actually creating. Then helped to create the Hog Foundation, which was the first major gift to the University of Texas system. This was back in 1939. We officially launched in 1940, so we've been around quite a while. And in fact, the Hog Foundation has been involved in the creation of the public mental health system of this state. Everything from the first mental health code, that was us, giving a grant to the UT Law School to help create that, to developing the first schools of social work, psychiatric centers, and even now, just recently, helping to create the new Dell Medical School, the UTRGV School, the DO School in San Antonio, University of Houston School of Medicine. We're involved in a lot of things. From the very beginning, in addition to funding, which is our main thing, right, grant making, is also being involved, luckily, within the policy of this great state that we have. Now, the state of Texas is growing tremendously, and it has for a long time, but even accelerated, especially during the 21st century. And so that makes for a lot of challenges. And there's a lot of also high-level population issues that we'll cover. So I want you to keep that sort of hat on. The other thing is that, as you can see here, we are part of UT Austin. However, because of our origins, and because we've been autonomous really since 1940, when we got a ruling from the Internal Revenue Service to create the Hog Foundation at the University of Texas at Austin, because it had never been done before. We have a lot of charge, or a grand charge, which is not to be specific or to be just a UT, the UT system, but our charge is actually, as you'll see, is really the state of Texas. That's our vision, that's our mission. And it is everyone that is within the boundaries of Texas. And as you know, like I said, big charge, we're over 30 million people now. Second largest state, obviously here in the U.S., except for Alaska. But population-wise, only second to California. So and you guys well know, being here in North Texas, how challenging that can be as we're trying to provide great care for the great people in our communities that live here. But it's a charge that we take on not only very seriously, but also happily. There's nothing better than to be able to serve. Well, so I'm going to take you through pre-COVID, and then we'll also cover COVID as well. We've been through a lot, folks, all of us, and it's a pandemic. And we'll get to that, which means everybody, I mean, the entire world has gone through this and still goes through this. A lot of us wanted it to be over long before it was. It's now, thank goodness, transitioned more into an endemic instead of a pandemic. But the consequences and the impacts remain. So what did we have before COVID? Well, we had all these factors that were affecting our populations. And there are quite a few. And they're very important, though, for the work that you do and the work that the Hogg Foundation does. Because it affects, especially, as I have written up there, racial and ethnic minoritized groups, low socioeconomic status groups, and also our rural populations. Texas is a huge state. Do you realize how big of a rural population we have? It's around 7 million. Do you know that is 7 times the size of the entire population of Montana? Just our rural population? All of New England fits within the state of Texas? That's how big we are. That's how much and how important it is to ensure that we're serving our communities well. But what are we dealing with? And of course, many of you know that, especially those of us that are in the behavioral health field. I'm a psychiatrist by training, and so stigma is very much top of mind always. Geographic inaccessibility, as we've been working to ensure, say, the collaborative care model gets distributed. How is it different from an urban area to a metro, suburban, to a rural, to a pioneer area? How do you ensure that we are actually, if we're going to be equitable and looking through an equity lens, which means providing care to everyone, how does that get done? What kind of resources are needed at each kind of that level, right? We know that people of color are unfortunately disproportionately uninsured. Texas has been one of the leading states who has refused to expand Medicaid. There are consequences that come with that. One of them being that we have a very large uninsured population. So that provides very unique challenges for us. Provider shortages and network insufficiency. Workforce, you guys know this, it is a rate limiting factor. It doesn't matter what model we come up with, and it doesn't matter even how many infrastructural resources we have. If we don't have you, we can't do it. And let me tell you, when it comes to behavioral health and psychiatry, child and adolescent psychiatry, woefully inadequate. Geriatric psychiatry, woefully inadequate. Forensic psychiatry, woefully inadequate. General psychiatry, woefully inadequate. We've had our hands tied. And part of that has to do that we just can't train and educate quickly enough. But remember what else I said, and it's also a consequence of being a vibrant state. We're growing so quickly. No matter how quickly we're creating resources, we continue to outstrip them. Those are dynamics we have to be aware of. And then we have to be very creative and think about, okay, how else are we going to be able to provide, with the resources we have, the greatest impact we can to ensure good, healthy outcomes for all our Texas communities. As you see there, and primary care is top of mind, as it should be, because who provides the majority of behavioral health in this country and in the state of Texas? It ain't guys like me. It ain't psychiatry. No, it's primary care providers. You always have been, and you always will be, the #1 actually provider of behavioral health for our communities. And so we have to find ways to work with you. But getting to the situation of, do we have enough people working in that field? No. And especially when we start to look at the diversity of the workforce, ensuring that it represents the society that it is treating, we have a lot of work to go. As you can see here, these are Texas statistics from 2020. Black Texans make up 12% of the population, but only 8% of our primary care providers. So if somebody chooses and wants to be seen by a black physician, it can be very, very challenging. Same thing with Hispanic Latino Texans. Almost 40% of the Texas population, but less than 10% of our primary care providers. As you can see there, we still have to do work on language capacity and ensuring we're providing either our providers ourselves are bicultural and bilingual, or maybe trilingual, depending on the area you're in. Some of our metro areas, like Houston, Texas, extremely diverse. Huge, large populations of Asian American population, as an example. It ain't just Spanish anymore, though Spanish is still pretty prominent. Bingo. We know how to use interpreter services. We've created the guidelines. The class has been around. We've even actually had a second version of it, but that is exactly correct. We don't follow those. Either our systems or our clinics feel that they are strapped resource-wise and can provide the appropriate resources as is needed, and so we still allow a child to be interpreting for an adult. So that's exactly inappropriate, and it shouldn't be done, and we know that. But when in the moment, what is the doc going to do? What's a nurse going to do? What's a social worker going to do? You do what you can. Doesn't make it right, but we do what we can. Lack of cultural relevant and minimally competent services, poor doctor communication, treatment engagement, health literacy. I was really excited to see Dr. Wagner is going to be on here. We've had her come and speak down at the UT Rio Grande a couple of years ago, because literacy is so important. And so health literacy, obviously, a very important topic. And of course, and you guys know this, our mental health and behavioral health clinics we haven't created an infrastructure for them to be robust primary care providers or to be tied to primary care providers and vice versa. Our primary care providers, they struggle to provide robust behavioral health and mental health services. How about the mental health factors? Those were just the general ones. Now let's drill down a little bit more into behavioral health itself. So we know that accepted use of mental health and substance use services, they are all medical care, in fact, is highly governed by these. But even more so when it comes to mental health and behavioral health. Why? Because now you're looking at actually the behavior, the way people interpret their perception of themselves, their perception of society is important and does impact them, and how it is being incorporated and results in tying to any biological aspects of mental health and behavioral health. Our population of color, very challenged when it comes to trying to find good services, and when they do get access, unfortunately, the studies show over and over again, they don't get the evidence-based care that is available. We have to change that, folks, because then you're not going to have the kind of health outcome that we should, and in fact, we have the kind of health outcomes and metrics that we do see, and they are, unfortunately, subpar for too many populations, which we call then disparities, because it's the difference between one population group to the norm. The workforce, once again, and I already kind of mentioned that, but here you see, these are US statistics, how few black physicians there are, psychiatrists, well, the other physicians, but specifically psychiatrists, psychologists, same thing with Hispanic and Latino. The current science base, we're making strides here. We're working very hard. The NIH has many programs, and NIMH as well, to try to change this, to ensure when we're doing clinical trials that in fact they're diverse, that they represent the folks that we're going to be treating. But historically, it didn't even include women. So there's gender differences and gaps as well in the research that currently exists out there in reference to what has been approved and what is considered evidence-based. We must continue to work on that. And it became very relevant during COVID. As an example, when they were coming out and developing the vaccine, what was one of the groups that was initially left out? Pregnant females. Why? Especially in this day and age. However, we did recuperate, we did recognize, and in actually short order, started to compensate. Same thing also for making and ensuring we were including people of color in the clinical trials for the vaccines. That was probably one of the quickest turnarounds that I've seen or adjustments made. And I think it's because we have a heightened awareness of what we need to be doing. Thank goodness. Kind of like cultural and linguistic humility, I think we've already covered that. And then, of course, why there is a reason that racial and ethnic minorities have a trouble with the trust factor. That is still a very, very, very important part of delivery of care. For you or me to go and see someone and to divulge to them the secrets you won't even share with your loved one or a partner so that you can, in fact, be treated well and have the issue at hand taken care of, that's a lot of trust, right? How is that going to happen if you don't? You're not even probably, we can build all the wonderful access programs in the world, but if we don't deal with the trust issue, it still isn't going to happen. So it's not a trivial matter, it's very important. It's already been mentioned, and I think you guys are all aware of the social determinants, and of course there's the social determinants of mental health as well. Dr. Ruth Shem has a really wonderful book out there. If you haven't seen it, you should, because it really, I think, succinctly puts together all of these issues that impact us. Some of the other terms that are out there are structural determinants. And now also what I think is becoming a little bit more popular, especially Health and Human Services Commission here in the state of Texas, is the non-medical drivers of health. But they're all referring to those factors out there, those systems that impact us, that we now know through research does actually have an influence on our health. We have a greater amount of knowledge and greater understanding of how to get good health now. Now we need to put that together and put it into action. So let me talk about a few of them, because they continue to pop up, and later I have another slide where I tie this to health outcome. But educational attainment, there are multiple studies over multiple years now that show the more education you have, the better your health outcome, regardless of race or ethnicity. But if you add in race and ethnicity, then it starts to also have a greater granularity to it. But as you can see here, unfortunately, our Blacks and Hispanic Latinos continue to have the lowest educational attainment, especially Hispanic and Latinos. Now, when you have a population that is 40% Hispanic Latino, and they got an attainment rate of 20%, that does not bode well for the future of Texas. We've done great historically, we're doing great now, regardless of all the other economic factors that are happening on a geopolitical level. Texas leads the charge when it comes to, creating healthcare, entrepreneurship, great business models. We're there. We're doing great. But will we continue to maintain that? Or we will need to then, because if not, we don't create it internally, what are you going to have to do? You're going to have to import it. Take it from other states, take it from other countries, if we want to continue the slope that we're on in the trajectory. So that's concerning. So concerning, take a look at just the Black unemployment is significantly higher than white unemployment, regardless of educational attainment. So when we do have educational attainment, the good thing is, as educational attainment does increase though, you start to see the gap really start to shrink. So that's good. However, there is still, though, a gap. And especially when you take a look at college and high school. And so we are not all experiencing, say, downturns, recessions in the same way, do we? And one of the things that is important, because we're a capitalist society, the United States of America, the 13 colonies, those are 13 corporations. And we have built upon that, and we're a mighty nation because of it. But it also means that where we have landed and where we see the greatest amount of wealth accumulation is with home ownership. But we haven't always been fair about how you attain that home ownership, have we? No, we have not. However, that is why we now have these statistics we're dealing with. And if you look at a 25 time frame, from 1994 to 2019, what has happened to that? Over the course of time, a little bit of increase for non-Hispanic whites. But for the other folks, it's pretty flat. The only other group that's made a bit of a rise is Hispanic Latinos, but still less than 50% home ownership. And home ownership provides so much to a family and to a community. It provides financial stability. It gives you flexibility. It allows you to create and be proud of something that you can then pass on to your loved ones. And so the Black middle class continues to fight very, very hard. And if you're not familiar with Bob Herbert's documentary, and you can find it on the web, I encourage you to take a look at it. It's a very good documentary that really goes more in depth into the fight for a Black middle class. But home ownership is the #1 asset that creates wealth for American families. And so it is very much in favor, it has historically been, for non-Hispanic whites, to the tune of 41 times more wealth between a white family, a non-Hispanic white family, and a black family. That gap is way too big for us to continue to maintain our neighborhoods. And think about, because of a capitalist society, how we distribute resources, which results in getting back to those determinants. Everything from schools to safe parks to beautiful campuses like the one we're on today. And the gap is pretty large between non-Hispanic whites and Hispanic Latino families as well. That second bullet, though, is even more compelling because that one is about who has zero or negative net worth. That is a very, very bad place to be in this country. 14% of non-Hispanic white households fall in that category. I would hope it'd be even smaller than that, even for non-Hispanic whites. Less than 5%, but it's not, it's 14. That's still pretty significant. But look what's happening to Hispanic and Latino in our black households. 1 out of 4 for practically the Hispanic Latino household is zero or negative. And practically 1 out of every 3 black households. How do you live and contribute in a society when you're struggling that much just to live? Well, what ends up happening, and I bet if any one of you I had asked before I put this slide up, what country in this world incarcerates the most per 100,000 population? Well, me, I would have thought maybe like Russia, China. You think of sort of totalitarian, regimes. But no, it's us. We incarcerate 655 individuals per 100,000 due to policies that we have instituted in this country. And unfortunately, and you know where I'm going with this, it's disproportionate. Who is the majority of the folks, percentage-wise, as a representation of their population group, is being incarcerated? It's black men. They're getting it the worst. The Summer of Justice 2020 kind of highlighted that for all of us. Then it became front and center. It was on every TV, every media outlet. But by golly, we need to change this dynamic, folks. We are losing way too many community members. And as we know, even though we vehemently believe in not guilty until proven innocent, I mean, that didn't come out right. You're innocent until you're proven guilty. But even if you are and you pay your debt to society, the ongoing trauma that goes with it and the stigma that goes with it. So how, if you paid your debt to society and then you're back and you're trying to provide for your family, how are you going to do that? We won't hire you. We don't trust you. In many cases, we won't even let you vote. Total disenfranchisement. What are we telling those individuals? Are we living up to our ideals? So it's very sobering. You put all of those together, and I've been talking to a lot of folks about this over the last 2 decades, and especially since I became Executive Director of the Hogg Foundation in 2008, that we are in a crisis. This country is psychically in a crisis. And the statistics, unfortunately, are bearing me out. I wish I was wrong. I want to be wrong. I care about this country, love this state, but we're dying. Suicide rates are way too high. In 2021, over 12 million of us seriously thought about ending our lives. And we're all here in the behavioral health field or in the primary care field. So you know what it's like to work with a person one-on-one. I think back to my clinical days and how difficult and challenging that was, but also how rewarding. And to create that rapport you do with an individual where you care about them, and then to then find out later that they took their life. It isn't just the person that is lost, but it's their family, it's their community, and it includes us. We suffer too. When you lose a patient, at least I remember my patients that I lost. It affects you emotionally. COVID-19 comes along. Gee, thanks a lot. That's all we need, God, another virus. Not like we don't have, a ton of them out there that are pretty dang serious. Now comes along this SARS-CoV-2. So, became a pandemic, and we know what ends up happening. Why? Because pre-pandemically, as I pointed out, all of those structural issues that we're dealing with, which all result in disparities, they were front and center and present. Question? Yes. Oh, I didn't look out there, sorry.
I just want to say something to you, and I really thank you for what you just said. My name is Krista Daniels, and I'm on a lot of boards. Monday, we did a job fair. That particular organization that I'm a part of, it's called United Black Contractors, and what we did, we set up a job fair, 1,000 black men that had come out of prison, and we said to them, we will hire you on the spot. It does not matter what kind of record you had. We're going to train you, we're going to teach you, we're going to pay you, you have benefits, don't worry about anything, the past is the past, let us walk with you. Out of 1,000 African American men, only 63 showed up. And out of the 63, we hired them all, but I kept saying, go out and get those and tell them to come. We're trying to help you so you won't have to go back in. And several of them stood and said to me, I am so grateful that you did this because I was contemplating suicide because nobody cared. I have children that don't talk to me. I made a mistake. I've made a mistake in life, but how do we move forward? So when you said that, I sat here and I cringed, fighting back tears because you're absolutely right. How can we help them move forward? Yes, we all have made mistakes, some greater than others. Some have made mistakes, and the reason why we don't know about it because they haven't gotten caught. And that's the situation. So yes. I'm so thankful that you did that and you said that, because even before you said how the statistics, I even told her African American men, the greatest that's incarcerated. So what can we do not only when they are incarcerated, when they come out, how do they deal with society as a whole?
Agreed, absolutely. Thank you so much for sharing that. One, commend you for your program. Those are the kinds of things we need more of. And two, the challenges that still come with even when you provide that. To build that trust, for someone to actually believe you really are going to follow through and aren't just saying it because it's the right thing to say. The other thing I didn't mention about the statistics, and you're right, it is black males, but unfortunately, taking a look at the new statistics over the last decade or so, our black females and our Hispanic Latino females seem like they want to catch up. And that is not a good thing. That is not a good thing. So, unfortunately, you're going to see a lot of these statistics that continue to show, but you take all that in together, and I bet if I had brought all of you together pre-pandemic, let's come together, say it was 2017, and I had each and one of you at the table taking a structural social determinant and taking a look at it and say, what impact would it have, do you think, and on which populations if a pandemic showed up? I guarantee you each and every one of you could have predicted this. You might not have gotten the ratios exactly right, but you know why this has happened. Why, in fact, the majority of deaths are from American Indians, our blacks, and our Hispanic Latino brothers and sisters. We all could have predicted that because of where we have been working historically. And so, populations of color have borne a lot. Now, this does not negate, nor does this undermine the number of non-Hispanic white folks that have lost their lives, the number of families that have been impacted. Like I said, this pandemic has hit everyone. And from a number standpoint, it's a lot more white people that have died. This is not trivial. And especially, you take into consideration other drill downs or granular levels like rural America. But for populations of color, why? Because we're more likely to be uninsured or we're underinsured. We're more likely to not have a usual source of care. The access thing, I think we've already covered. But more likely to be working in service industries where you can't work from home. Me and my team, the Hawk Foundation, when we got the message from the University of Texas president and said, we're shutting down, everybody work from home, it was easy. I go home. I have internet. I have broadband. All my team does. And if someone didn't, I got it for them. Within a week. It was nothing. Why? Because we have resources. Why? Because I know I'm privileged. I'm very privileged compared to the average person in our society, or the average person even in Texas. We need to be humble about that. But so many of us don't. And it's so critical and has resulted in COVID-19 having an impact. Because if you can't work from home, or as the next bullet shows, you live in a multi-generational home, or maybe it's not large enough. The guidelines we came up with at the CDC did not take into consideration, in my opinion, a lot of our communities. Not initially. They adjusted as time went by. But you're given guidelines about 6 feet this, and if you get sick, go home and isolate yourself. How are you going to do that if you live in a small house, you got 4 kids, and grandma and grandpa are with you? Where are you going to isolate? Well, you going to live outside in a tent? Maybe. I don't know what. Some families did what they had to do, right? Or maybe they moved in with a neighbor because to be able to not infect a family member. But we weren't very understanding initially. And of course, public transportation, that's another issue on its own. Mostly hitting the larger, like older centers like the Northeast and things, Chicago and such. Not so much here in Texas because we love our trucks and we have big highways, so we're not using public transportation as much as we ought to. Though we could definitely benefit from it, but that's my personal opinion. But what did populations of color experience? It's what's known as a syndemic. Before the pandemic, syndemic was a theoretical, almost academic concept that few of us talked about in the public health arena. But it came to bear and became real during the pandemic. And what is that? It's the intersection between, in this case, the virus, COVID-19, structural racism, which we deal with across different systems, and or in the health inequities and disproportionality that already affected people of color. Man, that's a triple whammy. That's really, really tough. And also understanding why certain communities have borne such disparate outcomes compared to others. Also made it challenging on how best to provide the resources, how best to treat, how best to bring folks in and provide them with what is needed to be able to get through this syndemic, and especially the pandemic. The other thing that happened, and I mentioned it, the summer of social justice, which was 2020, and all of you were all part of this, and you saw it and you heard about it. Many companies, many organizations, clinics, individuals, hospital systems were coming out and recognizing the impact of structural racism on our health. But what I wasn't hearing, and of course I'm more attuned to this, being a psychiatrist and being the head of the Hawk Foundation, why aren't they mentioning mental health? By golly, our mental health is being impacted. As the World Health Organization said many decades ago, there is no health without mental health. Hence the reason I felt compelled we needed to come out with a declaration ourselves. Not to add to the many declarations that already existed, because that, in my opinion, would not provide any additional benefit, but to highlight we must be cognizant of the mental health issues that are coming along with the pandemic. And so we did. And we released it in September of 2020. It was interesting that finally in January of 2021, the American Psychiatric Association also finally joined. But we were actually the first. By the way, one thing I didn't mention, 1940, when we were created, we were the first foundation in this nation that was 100% dedicated to mental health. There are many more now, But it was us here in Texas that had the first one. Now, why, is this important? For me as a physician, it's because racism has impact on us as human systems. And it has outcomes that are not positive. And definitely the individual who's directly affected. But the truth be told, everyone is impacted by racism. The one that delivers the racist remark, and of course the recipient. But look at our kids, children and youth. Let's start with those. Researchers have linked racism to poor birth outcomes. We're just talking about infant mortality rate as an example. Second bullet, asthma. How many of you deal with asthma? Quite a few. I bet you know that mostly black kids are the ones that are asthmatic. 40% more likely to experience asthma than white kiddos. And the American Pediatric Association has stated it is the most racially and ethnically disparate health condition in the USA. That's how bad asthma is for our black kiddos. Lead poisoning. There is no amount of lead that is good for the body. It is a one evil little element, folks. You don't want lead. There's a lot of reasons that I think from a private sector business component why we've created lead products. We used to have it in gasoline, as an example. There's reasons for that. Why it was in paint, there was reasons for that. But or in our pipes, water pipes, there's a reason for that, yes.
I'm from Northwest Indiana, and I've come from a town called East Chicago, Indiana. I went to a school on the other side of the tracks, so it just different. The other side, Kerry, gosh, those kids all had a high incidence of mental health issues, learning disabilities, where they found out 5 years ago that all the land on that side of town all had lead in the grass, and the highest was at the school.
Oh,
so
my
I
goodness.
just thought
Yeah, I mean,
it was
it can be
huge.
insidious, right? Lead contamination of the soil. Maybe it was a previous work site or something. Dust gets kicked up, you inhale it. Maybe it's now a playground, unfortunately. Yeah. And lead, what it does to us, or to our neurological as we're developing neurologically, or even already developed, it can still have impacts even for adults. It's just not good. And what does it lead to? As just stated, intellectual development and behavioral disability issues. Black children aged 1 to 5 living under the federal poverty line, so it's a specific group, but they are 4 times more likely to have elevated blood levels compared to the non-Hispanic whites. When a child who's dealing with those issues and has no idea, the family may not even know, and they're struggling in school, we historically, what have we done? We've blamed the child, or we blame the family, or we blame the mother. For those of you that are old enough, remember when we used to blame schizophrenia on moms? It was a schizophrenic mother. It's an old concept. It's a good thing you guys don't know it. So that was from the 20th century. However, it does make a difference. The American Academy of Pediatrics in 2019 stated that failure to address racism in the United States will, I quote, continue to undermine health equity of all children, adolescents, emerging adults, and their families. Our pediatricians are very worried about what's happening, as we all should, because regardless of what age you are now, at one time, you were a toddler. At one time, you were a child. At one time, you were a youth. Then you were a young adult. And whatever happened to us, and even perinatally, even so importantly, especially during organogenesis, will impact us for the rest of our lives. That's why these issues are important. I definitely am very glad, I'll just take a little aside here, that we are now more in a trauma-informed care environment and moving in that direction and making sure that our systems are trauma-informed as well as our providers. And that was a great development, but I don't think it's enough. We need to go more upstream. I think we need to be neurodevelopmentally informed. We need to get to the point where we truly understand when you're even thinking about creating another human being, and especially in the very first month, when we're not even aware that we might be pregnant, the impact of exposure to toxins, not to mention trauma and other types of stressors. Young adults, chronic stress exposure creates wear and tear. Multiple studies have now shown that. Increases the likelihood of, look at all these chronic illnesses that we now recognize and understand, and why in certain population groups that are more prevalent. Toxic stress. What happens if you are constantly being exposed to an environment that is stressful? Toxic stress happens, and it takes a toll on the human body because we are responsive. Even if you don't think you are, your body is. Your adrenal glands are working all the time. Cortisol levels are popping up. And if they contain and maintain a too high level, they will cause damage on the brain and the body. Auburn University study recognized premature biological aging. It's happening at a cellular level. Their study showed increased incidence of racial discrimination over a 10-year time frame. Showed signs of faster aging at the telomeres, which are the ends of our chromosomes, showing that biologically it does have an impact. What happens to our adults? Some of you have probably heard of the concept of weathering. Increased likelihood of, once again, cardiovascular disease and hypertension, and some cancers happening at younger ages when compared to our non-Hispanic white population group. Black women, 40% more likely to die from breast cancer. It's a real issue that unfortunately affects our black women. Too often, when it's happening, they are being seen and recognized, but the stage is way too late, and it limits what we can do. Because as you guys well know, nobody wants to have cancer. But by golly, if it does, we got to get that sucker the sooner the better. Older black Americans, more than twice as likely as Americans to experience dementia. But unfortunately, they're less likely to be diagnosed. Now, I mentioned about higher education attainment and tying it to something. I'm going to tie it to dementia. Take a look at this information and studies that have been done. Higher education attainment is associated with lower risk of dementia. So not only is higher educational attainment tied to better health in general, and especially now that the baby generation, which includes myself, we're at a retirement age, and we worry about that, or we're taking care of parents. I'm taking care of two in-laws, had to move into my home to be able to take care of them because they have dementia. Many families are doing that. We take the burden on ourselves. But educated older adults have lower prevalence of dementia, which means they have more years of being cognitively intact and less years, if dementia does show up, of living with dementia. And if anyone has treated, if anyone has dealt with, or anyone has a family member, you know exactly what I'm talking about of what happens over the course of time, because it's devastating. And the prevalence of probable dementia among U.S. population age 70 and older, I think that says it pretty well. If for any other reason, I'm going to go and get myself a college education just so I can prevent dementia, because it is a devastating illness. But look what happens when we start to throw in race and ethnicity and go down at that granular level. Disparities start to happen. So it should be no surprise, right, that 17% for Hispanics. Why? Because we have the lowest education attainment rate. There is a reason, and there is an association. Maybe not a correlation yet that we know of, but I think it's coming. So what is the overall effect of structural racism? It is really across the entire body. It affects us holistically. It doesn't just say, oh, I'm just going to affect your brain. Oh, I'm just going to affect your heart. Oh, I'm just going to affect your cells. No, it decides, I'm going to affect all of you. So how about COVID-19 and health and mental health? Because that was overall. Well, studies have shown that COVID-19 affected the kidneys. Acute kidney injury was pretty common. So you can see here, practically 37% developed acute kidney injury. But it wasn't the same for everyone, unfortunately. As you can see there was a difference between our black and non-Hispanic white folks. The second bullet was the one that was really kind of scary. I mean, all of it is scary to a certain extent, especially for those that aren't in the medical field and maybe don't understand the underlying sort of methodologies, the underlying biological components of this virus. Because the virus doesn't care who you are. It's opportunistic. All it's looking for is a host. That virus is just looking for a host to be able to replicate itself and then jump to another host. And what it does to you and how it devastates you, how you end up afterwards, it doesn't care. Because it's on to the next. If there's anything alien or evil, talk to me about viruses. Of course, maybe bacteria will say, hey, what about us? But yeah, you're all bad dudes. But the multi-system inflammatory syndrome in children, the MISC that came out, that we were aware of, thank goodness it was rare. But what was really interesting to me was the studies showing which were the kids that were really impacted. More than 70% of the reported cases of MISC were Hispanic, Latino, or non-Hispanic black kids. That wasn't as well, informed to all our systems as I think it should have been. Because we needed to be very, very vigilant. Thank goodness, like I said, it was rare. But the impact on our kids, as we all very well know, and hence the reason the population pushed back significantly. The closing of the schools, that was a bad thing. I'll tell you from a personal standpoint, it was a bad thing for my daughter. I have a 13-year-old. But she was in 6th grade when they did the closings. She's in 8th grade now. She did not take it well. Her mental health went down. My girl got depressed. She became very anxious. And she's still trying to recuperate from that. She's not quite completely back. My wife and I say, like, our girl's almost back, but not quite. Just that social isolation, losing that social touch that our kids have, that infrastructure of children, their teachers, it really, really hit her hard. And she was not the only one. Too many of our kids did that. These are lessons learned. I know that we get angry and what can't be done and stuff, but we need to also remember to step back and be a bit objective and go, what can we take from this to ensure we don't repeat ourselves and we do it better next time? Because folks, there's going to be another pandemic. I can't tell you when, but I do know there will be another. Or a devastating type of trauma of some kind, either man-made or by nature. We've dealt with Hurricane Katrina. We've got fires going across the U.S. and in Texas. So we have to be prepared and be able to do and take from what we learn. Continuous quality improvement. It's a great concept. And as you can see there, it affected also our kids when it comes to suicide and the number of ER visits due to mental health reasons. But one thing we also didn't know is how devastating it was to our older adults, and how, in fact, it has continued to actually remain devastating to older adults. If you take a look now at the statistics, because people are still dying from COVID, but who is dying from COVID now? Majority of folks are the older, over age 65, as well as, unfortunately, folks that haven't been had a vaccination fall in that category. And social isolation, we have great studies that show how devastating it is to us. You know why? Because we're emotional beings. We're human beings. We need each other. That's why also like in the mental health field, and we've known this for a long time, especially our individuals like our dealing with schizophrenia have a tendency to pull back from what we call the social drift, right? They pull away from society. We know the impact it's having on them and why it's so important to keep them engaged. Well, it's true for all of us, but also true for our older adults. Why? Because it increases heart disease, infections, depression, cognitive decline, and death. Loneliness and isolation will kill you. And older adults have experienced severe inequities when it comes to COVID-19 outcomes. That we know. The statistics have borne that out, and unfortunately, disproportionately. Let me also jump to, because I mentioned about the imprisonment thing, the criminal justice involvement here in the state of Texas. In Texas, we have a way disproportionate number of Black and Native Americans who are disproportionately incarcerated. So those populations are being impacted greatly. Black Texans make only 13.2% of the Texas population, but almost a third of everyone that's incarcerated here in Texas. That's a huge difference, folks. And you can't tell me that it's genetic. You can't tell me it's because they deserve it. You can't tell me it's just because you're Black. There's something wrong with that picture. And of course, when you take a look at just involved youth, and they have higher rates of mental health and behavioral health than their peers. Because of the system that we currently have in Texas, from a resource standpoint, what is happening now, if you're not aware of it, is the number of folks that are incarcerated in Texas, too large of a percentage of them are dealing with mental health and behavioral health issues. Okay, we know that, right? But what is that actually happening then in our Texas system, the criminal justice system, is that a great number of them are interfacing with our criminal justice system, are very ill. So ill that it gets to the point where many of them have no capacity. They're incapacitated, which means that they don't know what's going on around them. They don't understand the judge or the attorney or even the arresting officer of what's going on. And we're putting them in jails, and we're putting them in our Texas prisons, which are not equipped nor were they designed to provide behavioral health and mental health care. Mental health and substance use care, which is behavioral health care. So we have a very, important dynamic happening here because our system is not designed for what we're asking it to do. And these folks are being seen as being incompetent, not able to participate in the judicial system. And so what do? Let's get them the resources they need. Let's get them competent, that we can continue the process. But we're not able to do that because the infrastructure isn't there. So as of June of 2022, 2,400 individuals were on the forensic wait list. Waiting for what? A state hospital bed. And 70% of those state hospital beds are all being used now for forensic commitments, which means that they're not available to be used for the civilian population, which is the rest of us. Do you see where I'm going with this? Our system is collapsing on itself. Though we know what we need to do, we don't have the infrastructure and the resources to get it done because we're overwhelmed. Then you add in the workforce issue, and it's not just about the docs. A lot of our state hospital beds in 2020, 2021, and in 2022 had wings shut down because there wasn't nursing. That means those beds are offline. It's making the situation even worse. There are many programs, and the Hawk Foundation is involved with a great deal of these of how to hopefully correct that. Reduce the wait list is one of the programs that we're working with the NTACHC. But look at that. Over the last 20 years, we've seen a 38% increase in the rates of individuals who are incompetent to stand trial. Here's data from the Joint Commission on Access and Forensic Services. Excellent group of folks that, I know quite a few of them, working really hard, but it's tough to do things when you just don't have the resources. But what I want you to key on is that bottom bullet. Black or African Americans make up 35% of the people added to the maximum security wait list, compared to being only 14% of the population. And the same is true on the non-maximum security units. Getting back to your point, if we don't get them the care they need, we're not going to be able to get them to the point where they're going to be able to be functional individuals. And even if they do pay their debt to society, Will they be able to access the mental health, behavioral health services that got them competent when they're no longer incarcerated? And unfortunately, the data is showing that is a big ask. Approaches and solutions. I know this has been rather dire, but these are really big issues that we have to be aware of. Because as we all know, if we don't explicitly name a problem, if we don't recognize the issue, well, how are you going to work on it? We ought not to be afraid of these statistics or these issues or the communities that are being impacted. In my opinion, strength comes from accepting the truth, taking ownership and accountability, and then you say, let's work together and let's get it done. That's how we're going to move forward. And one of the critical things, and you guys are already doing it, is community engagement. And you know what? A lot of people talk about community engagement because of the Hog Foundation. I got my program teams throughout the state of Texas working with, on community engagement. A lot of people talk community engagement, but they don't know how to do community engagement. They don't have the skill sets. Easy to say, community engagement, yeah, that's what we need to do. Operationalize it, start doing it, and then you find out, holy crap, this is hard work. Yes, it is. But it's hard work that's worth doing because it's about us. Let me just highlight a few bullets. Respect and understand the history of the community. And every community has its own and different history. It's sort of like a collaborative integrated care, like Dr. Little was talking about. It has to be specific and tailored. So is the truth about when we're working with communities. And then, of course, it depends how you define it. Or do you define it geographically, or do you define it by other parameters of how small or how large that community is going to be? That will help you to understand how to approach it. Go to the 1, 2, 3, 4, 5. Go to bullet 5. I've mentioned it a little bit before. But there are a lot of factors out there that impact each and every one of us, day in and day out. Impacted my mom and dad, I had no idea when I was a kid. And our kids are the same way, not knowing that, even though mom and dad or uncle and aunts are all dealing with these issues. Don't blame the individual. Don't blame the community. That's too easy an out for their disadvantaged statuses. Recognizing and understanding how we now know how resources are distributed politically, how resources are distributed based on policy, how resources are distributed based on power and privilege. We need to understand those dynamics to be able to ensure equitable outcomes. Include all age groups. I think it's really important because one thing we do is we either say, oh, the young, yeah, they don't understand anything. Leave them out of the picture. We do have a conference coming up in Houston. We do it every other year. It's called Young Minds Matter. We actually have youth helping us to design the agenda of the conference. We have youth who are the panelists themselves, recognizing their expertise of being young and that lens that they have, but working closely with the adults and the elders to design it. Both learning, you see learning happening in both directions. It's a beautiful thing. On the other end, we're a very youth-oriented society. We're obsessed with staying young to the extent that we exclude our elders or don't think about older adults until it's an afterthought. Instead of recognizing there's a lot of wisdom. They've lived a long time. Geez, they must have acquired something along the way to figure out this world of ours. Let's bring them in. Really recognizing across the life spectrum, everyone is valuable and can help us to deal with the issues at hand. And I'll end with the last one. Build on the strength and assets of the community. Historically, including philanthropy, we looked at communities from a deficit perspective. What's wrong with you? What's wrong with your community? What don't you have? What do you need? Oh, you're asking again. All you do is want money. Yeah, those thoughts all go through philanthropy, or did. But we're getting much better. We're starting to recognize and see things from an asset-based perspective. And this is also true in healthcare. So when that person comes in and we're dealing with a one-on-one dyad in the clinical setting, remember to ask, what's going right? What are you bringing to the table? It really helps to not only empower them, it helps to empower you also. And it builds upon the trust factor that you see them as truly, fully developed individuals that are coming. Why? Because we have the expertise. That's why people come to us. Why do people come and see me when I was a physician or a psychiatrist? Not because I'm Dr. Martinez. Put in a different name, Dr. Smith, Dr. Vogel, it doesn't matter. But it was the expertise I was there to offer. But it's important to recognize, you know what? Individuals have expertise as well. Who else knows their life better than us? Because the majority of health happens where? Outside of the four walls of the clinic, outside of my little 30 or 15-minute engagement. Or if I was lucky, I had an hour and a half when I was doing an intake. Right? Now, I know the collaborative care model has already been talked about in how it transitioned from impact to what it is today. Another model is out there, and I bring this up because this is one that we developed with the Federal Office of Minority Health, the ICO, the Integrated Care Organization. And what I bring here about the ICO, and we had it published and everything, we did, all the academic stuff, right? But I think one of the things that we wanted to bring to the table that I still see needs to happen is really that the integrated care organization, and it could be an FQHC, could be a community health clinic, could be a private clinic, could be a hospital system. But is it really engaged with the community? Really engaged with the nonprofits out there that make our community, with community leaders, and understanding what are the social determinants that are impacting you. Because what happens here in Fort Worth may not be the same that's happening in Amarillo, right? So respecting that and going to and ensuring the objective of decreasing health disparities and really getting to integrate improved individual, family, and community health and well-being. The big health outcomes. So looking more upstream, but also ensuring that you're looking downstream. And then the role that you play to bring those two together. Very powerful when you do it right. Challenging to do. Easy for me to say, right? Because it does take a lot of collaboration, a lot of elbow grease, a lot of commitment. Leadership has to buy into it. It takes everyone, all hands on deck to achieve this kind of a model. One thing I should mention about the social determinants. The social determinants are objective. They're not negative, they're not positive. But what they are is, how do they impact you? As an example, if you have a child who lives in a community with poor schools, no economic prospects, it's not safe to go outside, those social determinants are all negative. And we know the kind of impact they potentially can have. We know, and we can all think about the individual who was able to escape that. But from a population standpoint, that population, that community is going to be suffering. Versus the community where they have good schools, great tax base, good homes, safe parks and environment. They're going to have a different trajectory from a population standpoint. Could you have the individual that is not going to do well? Absolutely. But those are exceptions. And we're talking about from a population perspective why it's so important to look at those social determinants. So that's why we should all be aware of them. How are they impacting you positively, and what is also impacting you negatively? Helps you to identify the gap and where you need to be concentrating maybe your resources. Because health equity is all about quality. If you care about quality health care, in my personal opinion, you must care about diversity. You need to understand health equity. And you want to be inclusive of everyone because it's going to require all of us together to achieve good health outcomes, which is good quality care. That's what I think the United States of America should be going after. The best quality care for all. We're going to, just like in the military, let's not leave anyone behind. It ain't right, ethically. And you know what? No matter if you're in favor or not, it will cost us. And it does. At a human level, either through morbidity or mortality, which is illness or death, or financially. Because all the folks that I'm talking about that are disenfranchised and aren't able to access, they're either being picked up by 911 or they end up in an emergency room. And that is the most expensive kind of health care to be delivering. And we sure as hell aren't a society where we are all in when it comes to prevention. Public health is the way out for us, in tune with our medical health system. But it's going to take a paradigm shift. Political Determinants of Health. Good friend of mine, Daniel Dawes. It's a good book. Recommend it because it really helps you to, he succinctly brought things together to go, the social determinants are influenced by who we are, which is we're political animals. Our policies and our politics do decide where resources go. And we all have a role in that. Who we decide to vote for, who we decide to distribute resources to. We have a role that we can play in that. And understanding that role really helps us then to be able to decide and influence our healthcare system, which is ginormous. One of the things that the Hogg Foundation has been working on for now, which is the 88th, 87th, since at least the 86th, maybe started with the 85th. But definitely in the 87th, we almost got an Office of Health Equity done. I personally believe, this is my personal opinion, I'm not going to say Texas, that an Office of Health Equity at Health and Human Services Commission would be very beneficial for the state of Texas. I think it would really help us to coalesce and to bring together all of the resources from that equity lens to be able to ensure that our communities across the whole state of Texas, from Amarillo to Brownsville, from El Paso to Beaumont, that we're all receiving the best care possible. Because I'm a taxpayer too, and I want every dollar to be used appropriately and effectively and impactfully. I'm not a person of waste. I am a physician today. That's not the way I started. I'm a former commercial real estate banker. I decided to go into medicine after the S&L crisis of the 1980s. There's been a wonderful transition. It's a great profession, and now I'm more into policy and into philanthropy. There are so many great things we can all do together. But don't tell me about not using a dollar properly, because that really gets my ire up. Every dollar counts. Every penny is important because it can make a difference if used where it needs to be used. So an Office of Health Equity, I think, could help us to achieve that goal. However, in the 87th, we almost had it. Speaker of the House was on board, had bipartisan support in the House and the Senate down in Austin. And at the very last minute, literally the midnight hour, it didn't get all the votes it needed, so it didn't happen. We put it forth again and tried to get it up in the 88th, but this time things were a lot different than in the 87th, and it didn't really get pretty much out of committee. So, but that doesn't mean, because policy is a long game, folks. It's a marathon. You lose today, you lose tomorrow, even you might lose even afterwards. But maybe it's the fourth or fifth time. It could take 10 years. It took us a long time, for instance, the Hogg Foundation working with many, many good stakeholders to get peer services recognized here in the state of Texas. But we did it. So I have hope. Why? Because I mentioned it. Because we all, each and every one of us in this room, throughout the state of Texas, even nationally, deserves a healthcare system that cares about us. Seamless integrated health, mental health, substance use care delivered in a cultural, linguistically person-centered framework at the individual, family, community, practice system, and workforce level. Tell me what's wrong with that. We all deserve it, in my opinion. Key point, though, let's be cautious. We don't oversimplify the values, customs, and beliefs that characterize any one group. Our uniqueness is our strength. We must respect each other. Let us celebrate our differences. Because only God can decide and parcel out if we've done the right thing while you're here on earth, for those of us that are faith-based. For those that are not, you have your own rubric. And I'm sure it's ethical as well. And practice cultural humility. No one knows everything. You know, when we first rolled out cultural competency almost 50 years ago, I mean, the pushback, well, how am I going to learn all those cultures? That wasn't the point. There's no one can learn all those cultures. That's ridiculous. But that was some of the pushback I remember. I'm an old guy now. I can actually look back 50 years, oh gee. But where we ended up is about cultural humility, which is understanding and respecting other cultures. That we can all do, because we can learn from each other. So encourage an open mind, recognize that each of us sees the world through our own very distinctive cultural lens and experiential lens as well. I'll leave you with two quotes from two folks that I think saw things in the future, or at least looked toward the future. Senator Robert F. Kennedy, 1968, some men see things as they are and say, why? I dream things that never were and say, why not? And then the Reverend or Dr. Martin Luther King. Talk about a visionary. Medical Committee for Human Rights, 1966. And I know some of you have already heard these quotes, but they're worth repeating. Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. He was true then, and he's still right today. Let's change his quote and let's make it truly historical. Thank you. Oh, is there time for questions? I don't know.
Yeah. Any questions for Dr. Martinez?
Sure.
Thank you for that. I oversee our health partnerships for Fort Worth ISD, and overcoming health disparities is our mission. And I'm also the chair of the board of Mental Health Connections. In Fort Worth ISD, we've had a system in place, mental health, for over 20 years to connect students into mental health resources. So typically we deal with about 3,000 to 4,000 students every single year. 60% of those are Medicaid and about 35% of those are uninsured. Yeah. Of those uninsured population, very few of those are going to be able to afford a copay. So we've worked with the community here for many years to build that support, and we've done well. What happened during COVID was counselors started getting paid. And so that health disparity, not only with the mental health, but with other areas too, but in particular with mental health, that health disparity grew tremendously because of the shortage of providers. Providers, because of the demand, could go into private practice where they can get paid a lot more than what they were paid at agencies. So throughout the community, there was a real workforce shortage, and that impacted ours. We were looking at 6-9 months for a time to get kids into care. And if you're at a school, you're wanting that next week, right? But we really saw that impact for the ones that need it the most because of that care of people being able to get paid and that demand for that. So we just had a mass exodus of providers that really hurt us. Right. So when you're looking at those factors, when it comes around again, you know, that really hurt our population tremendously.
Thank you for that comment. What you shared is, I think, is granular, what's actually has happened and you continue to have to deal with. It makes me think of a couple of things. Number one, I mentioned it, the workforce issue is just huge and tremendous. But here's where we are when it comes to behavioral and mental health. And it includes a lot of the docs, but it also includes like psychiatric nurses and social workers and so forth. And you just mentioned it, competing with the private sector. Okay, so pandemic, everybody's being affected. So everyone, my God, my inbox, constantly, every day, multiple times a day, come work for us, come work for us. And the numbers kept going up, $300,000, $400,000, $500,000, come work for us. Well, you know, people have to take care of their families too. So I don't blame individuals for taking advantage of an opportunity. But you know, it gets down to the basics of labor and capitalism, which is about supply and demand. And right now, the supply is so low and the demand is so great, and COVID exacerbated that, right? Then now we have a huge disparity just when it comes to the supply-demand. To undo that is going to take some serious hard work at a policy level. And until that happens, you're going to be left with having to put Band-Aids on stuff.
And you have a period of time where we've had a lot of ARPA and ESSER funds
Yes,
that are going away,
yes,
and that has helped tremendously.
yes.
But in a year from now, that's gone.
I know. And we're not like and we're not going to transition you. We're just going to drop the bucket or the floor from you. That is not the way to do things. We could do better. But that's already happening. So I will add one silver lining to this. So as part of the Hogg Foundation, I also work with UT Systems and our other health systems across Texas. And together, all the departments of psychiatry has a group called the Chairs of Psychiatry. And I'm lucky or honored to be part of that group. This was pre-pandemic. One of the things we considered in thinking about the workforce issue, especially child adolescent psychiatry, and the need for our school districts, was how are we going to create more child adolescent psychiatrists, or even primary care doctors and pediatricians with the skill sets that are needed for Texas. We said there's just no way we're going to develop enough residency programs. And by the way, it's going to take time. We need it now. We need it yesterday. So one of the things we did was that we decided to take a look at the Massachusetts Child Access Program, something that actually I had been bringing up and had presented at the Texas Society of Psychiatric Physicians a few decades ago of why isn't Texas doing this? Bottom line is we did it. Bingo. The Texas legislature, we asked and they gave us $100 million to stand it up. And when did we stand it up? During the course of the pandemic. We had no idea the pandemic was coming, folks. What we did know was about the need. Is it the full solution? No. But I think it is, like all things, it's a puzzle. And I think it's a big piece of that puzzle. And so the Texas Child Mental Health Care Consortium, of which I'm an executive committee member of, and there's much that I still think we can do to make it better, what it's been able and is starting to do, I think is pretty helpful. But it's not the full solution. However, yeah, there's TCHAT. We created child adolescent psychiatry fellowship programs. We've got research project going on in trauma care for kiddos now. What we did was, and they told us it couldn't be done. All 13 health science institutions in the state of Texas came together as a consortium. We truly are working as a state together to address the needs of our children and youth. And by the way, now it's morphing into perinatal care, and we're starting to look at what do we need to do maybe for general adult care and maybe even older adult care. Maximizing the use of technology. And we stood it up during the pandemic, and it just got refunded. Actually, at the 88th, so we're very grateful to our legislators that saw the vision of what we can do. But it's an example of what we can do. It doesn't help you completely, but it is starting to provide some resources out there. Another question? That was a good one. Yes?
Just referring to, obviously it takes physicians a long time to go to school and do all that, so that's a long-term solution to the problem of getting what's needed. But looking at the workforce level as far as nurses, I mean, a lot of nurses left bedside because of unsafe staffing ratios. So is there, the Board of Nursing across all, it's not just Texas, it's pretty much any of it. Are there conversations legislatively or what to get that more level? Because that would not fix, but help support until you get your physicians in there that can finish their schooling and to do all of their things to be participating.
Absolutely, I agree with you 100%. And yes, those conversations are happening. But I will disagree with you on one thing. Not until the physicians, because we can't do anything without the nurses. So it's a team. We've got to continue that. As an example, one of the other things the Hogg Foundation worked on during the 88th legislature, along with many other stakeholders, it isn't just us, we have the the reimbursement program for physicians to pay back their loans, the loan payback program. What we did and what we lobbied for and what was accepted, number one, it only had $2 million in the kitty. And we're going, are you kidding, for a state this big? Legislature heard us, boom. Now it's, they put in another $25 million. So it's a little bit more significant. But we also asked them, you have to expand that. And we argued you need to include our psychiatric nurses. It can't just be the physicians. It's got to be the other team members. Psychologists, we need therapists, social workers, as well as all the different types of nurses. So yes, and as a matter of fact, one of the other groups I'm with that's also, I think it was created by the '86 legislature. It's called the Texas Health. Oh, that's not me. That freaked me out. Where did I put my phone? The Texas Health Improvement Network. It's called THIN. We come together, and we just met August, and that was our primary discussion, was workforce, but inclusive. They said we have to include nursing. And so we're looking at how can we create different pathways now that, or that maybe exist and take them to scale, or if they don't exist, let's actually create them. What are we doing with, for example, with our AHECs? We could, that's a resources out there. What are we doing with community colleges? It can't just be looking at the higher universities and then the professional schools. It takes too long.